Welcome to the Myeloma Matters podcast, brought to you by the Multiple Myeloma Research Foundation. I'm your host, Veronica Borges-Med, Senior Manager of Community Engagement and Education, and I'm excited to dive into today's episode with you. In today's conversation, we're exploring an important phase in myeloma treatment, the transition of care after CAR T and bispecific antibody therapy. Now, for many patients, starting these treatments means going to a specialized center with the expertise to deliver them safely. Once that first step is complete, many patients are able to continue their care with their local hematologist or oncologist closer to home. This process is known as the transition of care. In part one of today's episode, we'll take a closer look at what this transition involves, why patients begin their journey at specialty centers, and how care is co-managed between academic and community teams. Then, in part two, we'll focus on the logistics, everything from scheduling treatments around family life and holidays to navigating inpatient versus outpatient decisions, managing travel and temporary housing, coordinating medical records between centers, and securing financial support. Before we jump in, I want to remind you that at the MMRF, we have a wealth of resources to help guide you through these processes. If you're looking for more information on CAR T-cell or bispecific therapy, be sure to visit our Myeloma Fast Facts in the Education Resource Hub at themmrf.org, or check out our high-impact topic videos on the MMRF YouTube channel. Joining me today for this important discussion are Dr. Joshua Dower, a hematologist-oncologist at Stamford Health in Connecticut, along with patients Kim and Annie, who will share their personal experiences navigating this stage of care. I'm thrilled to have them with us, so let's get started. Thank you all for joining our podcast and sharing your stories and experiences. Dr. Dower, I'm particularly excited to have you join us because of your pivotal role in helping patients manage their transition of care after receiving initial treatment with one of these therapies. First, can you tell us why patients who receive CAR T-cell therapy and bispecific antibody therapy often start at academic or specialized cancer centers?
Thank you so much for inviting me to join in this podcast and talk about this topic because it's something that I'm really passionate about and it's something that's really important to all of our patients who are facing multiple myeloma. So I'm really pleased to have been invited. You know, a lot of our patients who are facing multiple myeloma, who ultimately move forward with either bispecific or CAR T therapy, will start their treatment at a specialty academic center because that's the place where a lot of these therapies originated in terms of the clinical trials and the original ability to administer these treatments to our patients. So when we're doing this in an academic center, the patients are going to be receiving care from physicians and nurses who are extremely well trained and skilled at administering these medications and treatments safely and really adept at monitoring these patients really at the beginning. And then once that care is begun, then there's, of course, the transition back to the community center afterwards.
As a follow-up, how do patients find out where these treatments may be offered and how to potentially get one of these treatments?
When you're meeting with your physician in the community, that's when you're really going to learn about these opportunities and learn about where they can be begun and where to receive the treatments. So that's where it's all going to begin. But of course, there's a lot of online resources such as this podcast and other, helpful resources to patients to make sure that they're understanding even before they meet with their physician what could be next in terms of treatment for myeloma.
I'll pivot it over to Kim and Annie. I'm so glad to talk to you both today. Can you tell us how you came to receive your treatments? Kim, I'll let you answer first.
Well, gosh, I was diagnosed in 2009, so I've been doing treatment for a long, long time. Right now I'm on bispecific teclistamab. I've been on that since March of 2023, I believe. And right now I had care down in Levine Cancer Center down in Charlotte. And I received my initial dosage there, the step-up dosage for a week. And then eventually found a local doctor here in Asheville that was authorized to give teclistamab. So about 6 months I was going to Levine every week. And then I found a doctor here locally, and now I get my teclistamab here and follow up with my doctor at Levine in Charlotte.
Again, thank you for having us. I think this is really important to get this information out to everyone because logistics are really hard with this disease. I came to receive care at the local community hospital first in Stamford, Connecticut, which luckily for me is right in the area where the MMRF is. And I also knew a friend of mine who actually had multiple myeloma. So I had a great resource from the very beginning who was also being treated at Stanford in the Stanford healthcare system. So I already knew, honestly, that I wanted to get a second opinion at a larger hospital, and that was at Dana-Farber, which worked out really well for us because logistically it was close enough, but we also had three children living in the Boston area at that time. So it was sort of a known institution, reputable institution that I knew I'd have to get a second opinion on. And again, at least I knew the playbook for the beginning of multiple myeloma, which I was diagnosed in 2017 and had a stem cell transplant. And that was, again, through this specialized treatment. So I've been in this treatment care, as Kim has been, for a long time.
Dr. Dower, what role do you and the myeloma specialist play when patients are considering these treatments?
When I meet my patients who are facing multiple myeloma, I always remind myself and I remind the patients that multiple myeloma is extremely different for everybody. It's a disease, but it's a different experience for each person. And because of that, the care really does have to be personalized and individualized to every patient that we're treating, which is a really important thing to remember. And it's also important to remember that people with multiple myeloma live well and can live well for many years with this disease, as Kim and Annie are really great testaments to, which is fantastic. And whenever I meet a patient with multiple myeloma, the role I play is to really evaluate them as a person and really understand everything about them. Working in the community gives me a great opportunity to get to know my patients really well. And it's not just learning everything about their medical history, but it's learning about who they are as a person and where they're coming from, who's in their family, and what social supports they have, what medications they take, and all the other different factors that really make up who they are. And all of these things really do play into the consideration when we're talking about CAR T. So I always think about patients' age, their medical issues, and all of these social factors that I was just mentioning when considering these types of patients. And then it's also very important to consider the importance of coordination of care beyond just the medical part of this type of therapy, because there is a lot of logistical planning that is involved with the treatment of this disease with these types of treatment options. Are you going to be getting your care close to your home or further away from home? Who's going to be the person that can help you to receive this care? And how do we coordinate the transition back to closer to home after that care has begun? So there's a lot of different things that get put into the consideration. And we talk through all of this as we're kind of in the planning phases and recommendation for something like CAR T or a bispecific.
I just wanted to be a testament to Dr. Dower, who is my doctor at our local community hospital. And he does know everything about me and my family and our pets. And we have a great relationship. And I know he also has a great relationship with the doctors at Dana-Farber. And it really is true. And I will say, as Dr. Dower said, the nurses, I mean, you go to the hospital, well, I go at least once a month and see him and get treatment. And so it is a team with all the nurses, the phlebotomists, everybody in your care team. It's really important to have that trust and know that they will be there for you and know you.
Kim, how easy or difficult was it to find a myeloma specialist?
Oh gosh, back in 2009, I was in St. Louis at the time. Of course, I had been through cancer with both of my parents, so I was familiar with the whole process of finding a physician, finding one, not liking one, firing one, find another, second opinion, and all of that. So I went to my gynecologist actually, and I said, "This is what I've got. Where would you suggest?" And from that point on, he got me in touch with a local hematologist oncologist, who then, when I did my first stem cell, got me in touch with Siteman Cancer Center. I'm telling you, the doctors, you have to advocate for yourself. You have to ask questions. You just have to do your own homework. But the nurse navigator at my local oncologist was huge in getting me in touch with Siteman. And then from that point on, Siteman got me in touch with, when I moved to Asheville, someone at Levine, went to Duke, went to a couple of other places just to see where I felt that it was the right place for me. Ended up staying at Levine, and I've been there ever since. So the doctors do go hand in hand. That's it. And the nurses, I agree with Annie and Dr. Dower. everybody is there to help you. And you just have to ask questions. And if someone doesn't have the answer, don't quit asking questions until you get the answer and find someone who can help you. I think that's huge. You do have to advocate for yourself, and your doctors and nurses will advocate for you as well.
Annie, how did you settle on your local doctor and myeloma specialist?
Honestly, it's because I've lived in the Stamford, Connecticut area my entire life and came to my diagnosis by my actually, interestingly enough, the first one was my gynecologist who took some blood and then sent it to my primary care doctor. And he looked at it and he said, there's something wrong here. But it maybe the test is wrong. So I retook it in about 5 days and like, nope. So because I was already involved in the Stanford health system, that was where I went to get the initial diagnosis. So it was relatively easy. And then once I got the initial diagnosis, of course, I went to the MMRF website immediately and looked at their information, and knowing that Dana-Farber in Boston was one of their connections, I knew that would be the place where I would get my second opinion. And knowing that Stanford didn't offer stem cell treatment or CAR T cell therapy, I knew that I would go there. So it was, luckily for me, it was relatively simple because I live in a metropolitan area. And I will say the myeloma family of doctors is a pretty small network, because I think that the local community doctors usually have done internships or fellowships with some of the bigger institutions. So their connections to their prior experience is also really important.
I'd like to pivot into how ongoing treatment and monitoring happens once patients are back at their local oncology practices. So I think patients are interested in understanding how often they'll have to see their local doctor or their myeloma specialist. So, Kim, what has your experience been like?
Well, at Levine, I go see my doctor there about once every 3 months, 3 to 6 months. If I can't make it down to Charlotte, obviously it's a 2.5 hour drive. I can do a Zoom call with her. I see my local oncologist once a month to do blood work, port flushes, and treatment. And a really good thing that helps with my local oncologist and my one down at Levine is they have access to the same network to get into to look at my labs, my doctor notes. It's not the same healthcare network, but I don't know how Dr. Dowes, you probably know it. They can log in, and my local oncologist can see what's happening at Levine, and Levine can log in to see what's going down here locally. Therefore, you don't have to say, hey, to one doctor, did you forward my blood work to my research team, Dr. in Levine, or vice versa. That eliminates a lot of the hassle of having, a local oncologist versus one that's, like at a bigger medical center. And that was key.
Annie, I'm assuming your experience is a bit different since you were treated with CAR T cell therapy. What can you tell us about how your ongoing monitoring has been handled locally?
It's been handled beautifully by my friend Dr. Dower here. But CAR T cell therapy, for the 3 months or so afterwards, you need to follow up with your treating institution. So it's a little bit different. So after I left Boston, I had to go back there every 2 weeks, and then it was every 4 weeks, while also seeing Dr. Dower in Stanford. And I would agree with Kim. It's been epic since Stanford Hospital joined the Epic portal, which a lot of the bigger institutions already had. I mean, it is game changing. So they don't have to fax things up to the other institutions like they did when we started this journey. So, yes. And well, I'll see Dr. Dower on Friday, and then we will make a plan going forward as to how often I will see him. But generally, it's about once a month. So you have to, build that into your own family calendar.
As a follow-up, in general, I mean, Kim and Annie, you both received different treatments. So curious to hear if you both had caregivers that were involved. Like to kind of understand potentially at what part of your treatment were they needed most. Kim, if you'd like to start first.
Sure. Oh gosh. I've had 2 stem cell transplant that was the biggest time. My husband is my caregiver. Of course, I have 3 boys too. 2 of them are grown and one's 18, and they were all a part of it. But my husband, when I had both of my transplants, was at the hospital with me. I was in the hospital for 3 weeks. He was there 24/7 at home. Stem cell transplants are rough. I was down 2 or 3 months, so I would have someone at the house with me just because I was so weak. I needed someone to help with making meals, being near if I was coming down the stairs. As far as my treatment now, I mean, I go to my appointments by myself. Initially, with the biospecific, my husband would go with me because I wasn't sure what side effects I would have, but pretty much don't have any. So I pretty much go to my appointments on my own, have a friend meet me, we'll go for coffee afterwards. The way I look at multiple myeloma, you just have to look at it as if it's just a chronic disease and it's going to be with you. It's never going to go away. And so I just look at it as it's just part of life and just go with the flow. Andy, how are you doing with your caregiver situation?
I am very lucky. I have 5 children and 1 husband and a dog, and they've been part of this journey from day one. My stem cell transplant early on, luckily for us, we had 3 kids that were living in Boston when I did the stem cell transplant. So everybody would just cycle in and out. And then when I came home, I do think, well, I will say, I think being a patient is actually easier than being a caregiver. So I really reached out to a lot of our friends, and luckily my sister lives in the next town over. And so when I came home after the stem cell transplant and after CAR T, I really had friends that stepped in, and because I think it's a lot on the caregiver. So I was pretty conscious of that. In the CAR T experience, I did it out of the hospital. So but I had to be in Boston for a month and close to the hospital. And so that really was a huge issue. Luckily, my husband could work from home, so he was there, and that is a very daunting problem, I think, in this system, because the treatment is ongoing, and the therapies like the stem cell and CAR T, really you need 24-hour care for months at a time. And so I think talking to other people, talking to people at the MMRF, I do think both the treating institution and the community hospitals have a lot of resources that they can direct you towards, like a nurse navigator or a social worker, to help you find housing or to help you find somebody to drive. And that, again, goes back to asking the right questions and advocating for yourself. And I will say that insurance, you've really got to fight for insurance to get the ability to get things paid for, like housing, like food, when it is necessary. Not everybody can afford to take time off for work, et cetera. So it's a chronic disease that actually takes a lot of time to be your own advocate.
Dr. Dower, I'm going to pivot back over to you. When patients are back in your care after initial treatment at a specialized center, what are your specific responsibilities with each patient, and how often are you communicating details of the patient's case with their myeloma specialist?
Yeah, absolutely. I think this does look a little bit different for patients who receive CAR T versus patients who receive bispecific therapy, but the general concept is pretty similar. Typically, these treatments will be initiated at an academic center, and then thereafter, patients will return to their home and they're going to be receiving ongoing care and monitoring at the local community center. So with bispecific therapy, typically the way it looks at the beginning is there's kind of an initial ramp up period of treatment, which typically lasts about a week or so, and then the patient can transition back to their local center to continue to receive ongoing care, which, depending on the treatment, could be weekly, biweekly, or even once a month, depending on the circumstances. With CAR T therapy, typically what will happen is the patient will receive the CAR T treatment, which is what we consider more of a one and done type of a therapy experience, where they receive the treatment, and then there's a close monitoring period for the first 2 to 4 weeks right after the treatment is administered, where the patients really do need to be close to their academic center. And as more time goes on and we understand the side effects and the experiences for patients, they can then return to their local center. Once they come back into my care, my job is really to make sure that we're continuing to move the care forward. With myeloma, as Annie and Kim have been commenting on over and over, it really is a chronic issue that despite everything, we can't really make go away. But the fortunate thing is people can do extremely well for really very long periods of time with this disease. So that's the really exciting part about myeloma therapy. Right now, when the patients come back into my care, when it comes to bispecific therapy, I'm overseeing the administration of the treatment and continuing monitoring, looking for side effects, watching labs, and making sure that we're preventing any infections and any other potential side effects. With CAR T therapy, it's ongoing monitoring of labs and side effects and long-term effects that could be related to either of these treatments. So we do typically have meetings on a regular basis, maybe once a month or every 6 weeks, depending on the situation, where we're going to do physical exams and labs and making sure that everybody's continuing to do well and live well with this disease. And, it's important to remember that while this is going on, patients will still have a relationship with their academic center. And as Kim was mentioning, it sounds like you go down to Charlotte a few times a year, and typically our patients will go to see their academic specialist maybe once a year, 3 times a year, or maybe not at all. It really depends on the patient's relationship with their team and what they're interested in continuing and what resources are available to them and what works best for them. I have regular communication with all the other myeloma specialists who are also part of the care teams for my patient. As Annie did mention, the myeloma community is relatively small in terms of the physicians who do treat this disorder, which is great because it's easy for me to communicate with all the different academic centers. At Stanford specifically, we have a great relationship with Dana-Farber, and I have regular meetings with the Dana-Farber team about once every other week where we talk about all the different active patients and make sure that everybody's on the same page with regards to their treatment plan and making sure we're moving the care forward. So it's a great opportunity for me to continue to work with other teams, learn about what's new in the field, making sure that all the treatment and care that we're administering and the monitoring is going smoothly and the patients continue to do well, because at the end of the day, it's really to serve all the patients that come to see us. And we're happy to continue to push that needle forward and continue to make sure that patients are doing well with this disease.
As a follow-up, if there are any, what challenges do you face potentially in managing ongoing care for patients when they are also co-managed by a myeloma specialist?
Yeah, I mean, in general, we're lucky because in the community, even though a lot of the academic centers kind of will initiate some of this care, we do have a lot of excellent resources and strong team members, physicians, nurses, and other ancillary staff members who are able to continue to administer the care. I think the logistical challenge of trying to continue to receive ongoing care both in the community and in an academic center in terms of physically being able to come and go to these academic centers can be the biggest challenge for patients, especially, depending on different social circumstances and what caregivers they have that can help them with transportation and, time from work. And I do appreciate that it is a big challenge. A lot of our patients who have multiple myeloma are in their 40s, 50s, and 60s, and they're still working and they have young kids. And there's a lot of other things that are have to be taken into consideration when continuing this complicated care. But it's all for the benefit of you and for everybody that is facing this. I try my best to try to balance all these things when I'm thinking about what's next and what's going on right now.
I'm glad you mentioned those logistical items for patients that are really important to keep track of, as that's a great segue to part 2 of our podcast. In the next episode, we'll dive deeper, looking into travel and housing during treatment, inpatient versus outpatient choices, cost and assistance programs, and how to advocate for yourself and your family. If you have questions, call the MMRF Patient Navigation Center at 1-888-841-6673 and visit the mmrf.org for resources. I'm Veronica Borges-Med. Thanks for listening, and we'll see you in part 2.